The first one is to try to define the concept of depression in a way which would make sense to everybody involved, which means medical practitioners, patients, and the carers. And the other one is try to encourage the development of new way of talking about mental health and mental illness, just more generally. I think to anyone who has had any experience of depression or being a carer of somebody with depression, well, it will be clear that there are certain patterns of thinking which are characteristic of people suffering from depression. And I think that mainstream psychiatry is aware of this, but cannot really pinpoint those ways of thinking characteristic of depression because mainstream psychiatry doesn't have a language to do it with. And in this talk, I'm using as my main point of reference the so-called Bible of Psychiatry called DSM-5, which is the Diagnostic and Statistical Manual, 5th edition. But I also want to refer especially to cognitive therapy, to Aaron Beck's work. He's the classic in this area, and then his successor and daughter, Judith Beck, if I get time to get to it. So, for example, I'm quoting from DSM-5's diagnostic criteria for depression: feelings of worthlessness or excessive or inappropriate guilt nearly every day. Well, I think this sort of does hint at ways of thinking. However, it doesn't actually identify any thoughts characteristic of patients, of people suffering from depression. People just don't think like this: oh, I have feelings of worthlessness, or I have feelings of excessive guilt, right? So this is from a third-person perspective, from the psychiatrist's perspective, not from the patient's perspective. Well, using Minimal English and NSM, in fact, we can try to get into the patient's thinking, such as, well, I can't do anything. I can't do anything good. I'm no good, which is really very close to how patients talk. So the first move here, it seems to me, should be from the third-person perspective to a first-person perspective. And then going, of course, leaving behind all the technical and complex English and trying to focus in on identify authentically the patient's ways of thinking. The same applies to cognitive therapy, such as Beck's work. It's for cognitive therapy, the main idea is that patients' thoughts are distorted, and that we need to identify their thoughts and then to help to show them what their thoughts are, those thoughts which are depressogenic, as it is called, right, and how to change them. But it seems to me it may be difficult to help the patients to change their depressive thoughts if you don't identify them in a way which the patients could relate to. So here I'm moving to section 3, which is a kind of detour, which is about anxiety disorders rather than about depression, just because in order to identify, to show you what the most characteristic depressive thoughts are, well, I think it's good to compare it with something else. So I've chosen to compare it very briefly with anxiety disorders. And you have belong quotes there from DSM-5, which I'm not going to read because I don't have the time for it. But essentially, you can see what the key terms are, which are used about anxiety. And they do talk about ideation typical of anxiety disorders. And I would prefer to talk about patterns of thought, patterns of thinking. So they talk about anxiety, worry, apprehensive expectation, threat, and so on. And all these terms are, I think, locked into the conceptual vocabulary of English. They don't, well, they are not cross-translatable, and they don't really express, they don't even try to express, it seems to me, the patient's thoughts. Yeah, so specific cognitive ideation. So using minimal English, we can sort of zero in on those specific cognitive ideation for each disorder, mental disorder, and compare them. So, for example, well, in the case of generalized anxiety disorder, it seems to me that the key thought is something very bad can happen to me, and possibly sometimes also something very bad can happen to me now, or sometimes something very bad will happen to me now. Whereas for depression, those typical thoughts are, above all, I can't do anything good, and possibly also nothing bad, nothing good can happen to me. So you can see very clearly what these differences are. And then I have a lot of examples from Beck, who really, because he was into cognitive therapy, he was trying very hard to identify ways of thinking characteristic of depression. And he did it in two ways. Well, he actually used a lot sort of English words which are used by patients, such as loser, or I'm a loser. And he describes depression in terms of your proneness to think I'm a loser. Well, okay, but Polish doesn't have a word like loser. Italian, I don't think, has a word like loser. So presumably there is some pattern of depressive thinking or thinking which is common for Polish patients and Italian patients and English-speaking patients. So loser cannot be what identifies this distorted way of thinking. Yeah, he also talks about depressive patients. Maybe I will quote a little bit. That's from 4.2.2. In order to understand the cognitive approach to the treatment of depression, it is necessary to formulate the problems of the depressed patient in cognitive terms. Because of the dominance of certain cognitive schemas, he tends to regard himself, his experience, and his future in a negative way. Yeah, but what does it mean to regard yourself and your future in negative terms? Again, what sort of distorted thoughts actually could this relate to? And then he talks a lot about loss and how you think about yourself in terms of what you have lost. But I mean, again, this is totally not translatable. And Beck recommends as one of the main techniques for cognitive therapy to get the patient to write down their what he calls automatic thoughts, those thoughts which are troublesome, which are depressogenic in one column, and in another column write some kind of rational response. So that's pointless to try. That comes under 4.5 on the handout, I think. So we can look at that. So this list comes from one of the tables from Beck. Pointless to try. Will feel worse if active. Will fail at anything I try. No point to living. Too miserable. Need escape. Cannot cope with obligations. Nothing will work out. Activities do not mean anything. Am defective, weak, etc. I should be more adequate. I'm responsible for my problems. I'm overwhelmed. There's so much to do. I can never do it. It seems to me that there is a mixture here. There is a little bit of sort of patient thinking, but there's also a lot of things that patients would not say. Like, for example, it seems to me that activities are meaningless. I mean, a patient that wouldn't write something like this, right? This is sort of a psychiatrist's talk, it seems to me. I'm defective, weak, I don't know. But no point to living. Yes, maybe. And will feel worse if active. I don't think the patient would use a word like active in what they would think or say or write. So it's a mixture. But much of this, of the patient's thinking, is recoded here into the psychiatrist's language. So it seems to me that, well, yeah, it's true that one good and important thing to do is to record as much as possible of authentic patient utterances, and such as, for English-speaking patients, I'm a failure. It is all my fault. I'm a loser. I hate myself. There's so much to do. I can never do it. I'm not, yeah. But it's also good to try to identify patterns of thinking, meanings. characteristic of the patient suffering from depression, not just these words, which are not standardized. Well, of course, they are not cross-translatable. You cannot use them in different countries, in different languages. But also there is a lot of variation between speakers, whether somebody says I'm a failure or whether they say I'm a loser. That there is a thought behind that which needs to be identified. And this thought can be identified, I think, through minimal English, actually through NSM. So I put some examples of this on under 4.6 in the handout. I just arranged them under certain keywords, but this arrangement is not, it's just for convenience. So I can't do anything. I can't do anything good. I have never done anything good. I will never do anything good. I have to do some things. I can't do all these things. I know that it will be very bad if I don't do some things. Well, I know that I can't do it. And so nothing good will ever happen to me. I will never feel anything good anymore. I'm a bad person. I'm not like other people. Other people can do very good things. I'm not like this. I can't do this. Okay, well, and then these thoughts about living, and I don't want to live anymore. I want to die. It will be good for other people if I die. If I live, I will always feel something very bad. I don't want to live anymore. I can't live anymore. I can't live like this anymore. It seems to me that these thoughts are really don't depend on English, that they occur, I presume, in depression patients in other countries as well, and they can be very well captured, it seems to me, in this way. Okay, so I'm now moving to my purpose of my goal of defining depression. Well, I have to skip most of the discussion which leads to it. It's all based on diagnostic criteria and diagnostic features from DSM-5. But maybe I will take you straight to what I propose, and then I can, if anybody wants to hear, how this is related to the kind of thing which DSM-5 says in technical English. So they have lots of diagnostic criteria, well, essentially A, B, and C, but under A they have 8 different possibilities, and of these 8, 5 are more important than the others. But there are 2 criteria which seem to be essential for depression, according to DSM-5. Well, one of which seems to be essential, required. So what are they? Well, depressed mood. That's the main diagnostic criterion for depressed mood. And this concept of depressed mood is so somehow salient in psychiatrists' thinking, well, in Australia, from my experience, that they actually talk to patients like this. The first question they ask, well, what's your mood? What has your mood been like? But the word mood is not used in ordinary English sense of the word mood. It's a technical term, which they have in a glossary, too. So, I mean, how is the patient, to understand this question, how has your mood been in a clinical sense? Well, actually, I have a go at this too in the handout. I try to sort of analyze, guess what psychiatrists mean when they asked patients this question about how has your mood been. Let me just try to find it. Yeah, well, it's in 5.5. It seems to me they're actually asking 2 questions here. How have you been feeling most of the time? And what have you been thinking most of the time? And these are somehow amalgamated under this question about mood, which is never explained. Okay, so maybe I should now move to some of those other criteria. So the first, sorry, I'm getting a bit disordered here. So the 2 criteria which are required are either depressed mood, which I have now tried to explain in terms of how have you, have I tried to explain it? Well, in terms of feelings and thinking, which should be separated. And then there are 2 additional criteria, which are not as crucial, but also regarded as important, which DSM-5 lists as a list of things, and without any generalization. So what is the list? Well, insomnia, weight loss, fatigue, recurrent thoughts of death. What is all that about? Is this just a list of very different things, or do they have something in common? So I've tried to understand what they mean by this, and I try to put it find the generalization through minimal English in 5-6. So while you were suffering from your depressed mood, which I have explained in minimal English, at the same time it was like this. Some bad things were happening in this person's body. This person often thought like this: I want to die, I don't want to live anymore. So all these things like insomnia, weight loss, fatigue, and other things, well, maybe can be understood in terms of this one generalization. Some bad things were happening in this person's body. Well, that's, of course, debatable and open to discussion. And the other thing, which is very important for depression according to DSM-5, is quoted here under 5-7. So the symptoms cause clinically significant distress or impairment in social, occupational, and other important areas of functioning. What does that mean? Well, here's my tentative minimal English translation. Because it was like this, during that time, the person couldn't live like before. I hope that's really what it's all about. So, yeah, and I didn't mention, I keep omitting this other crucial criterion. So it's either depressed mood, which is required, or loss of interest and pleasure. Is that right? Loss of interest and pleasure. So there seem to be two variants of depression implied by the DSM-5. I don't know whether they are conscious of it, because they don't really talk about two types, but they have those two crucial criteria. It has to be either depressed mood or loss of interest and pleasure. And the other things are the same, which is the something bad happening in this person's body, and also that you can't live like before. So here are my two tentative explications for two different formulas, for two different variants of depression in 5-8. So the first variant: for some time, not a short time, it is like this. Every day, much of the day, someone feels something bad because they think like this: I can't do anything good, nothing good can happen to me. At the same time, it can be like this: some bad things are happening in this person's body. This person often thinks like this: I want to die, I don't want to live anymore. Because it is like this person can't live like before. And I will read the second variant, which really only differs from the first one in the first segment, in the first component, well, in the second line, I think. For some time, not a short time, it is like this. Every day, much of the day, someone doesn't think like this about anything. I want to do it. It seems to me that this loss of interest or pleasure perhaps can be captured in this generalization, that they can't think about anything. I want to do it. When they are doing something, they don't feel anything good because of this. At the same time, it can be like this. Some bad things are happening in this person's body. This person often thinks like this: I want to die, I don't want to live anymore. Because it is like this, during that time, this person can't live like before. So just very quickly, in 1 minute, well, my conclusion. I stated my goals at the beginning to try to formulate the definition of depression. I came up with two variant definitions of depression, which tries to connect with what the psychiatric literature, especially the DSM-5, is saying. And at the same time, I try to explore the possibility of talking about thinking about mental illness and mental health, well, in words which are clear, precise, and cross-translatable. Thank you.